Okay, so hello, my name is Jacob. I'm a student physical therapist assistant. Today I'll be discussing with you about your newly diagnosis with Parkinson disease. So, with Parkinson disease, let's go over the etiology. So, with Parkinson disease, the way that we acquire it, let's look at it. It's the broad term of Parkinsonism, which is going to be the general term that we're referring to it as a disturbance in the uh, basal ganglia. And so, what that means is that the basal ganglia is a part of our brain that produces dopamine. And that dopamine is a neurotransmitter that helps send signals from our brain to the body to initiate complex and intentional movement and how to stop it as well. And so, with Parkinson's, you're really looking at some primary causes, which is going to be the majority of it. So, like around 78% of it is going to be idiopathic, and we're really looking at it as the body is spontaneously acquiring it. We don't know the certain causes of it, whether it may be related to genetics or a disease. Uh, but there's also the secondary way of acquiring it, which is either through toxins, drugs, tumors, metabolic deficiencies that might be affecting and triggering Parkinson's to arise out of your body all of a sudden. So there's different ways of really acquiring Parkinson syndrome, and so I really want to focus on how it affects the body. So the main way that we're going to be looking at it is a dopamine deficiency. So what I mean by that is that basal ganglia, there's a little part called the substantia nigra, and that part produces that dopamine. And so when your body is low on dopamine, your body won't be able to function as efficiently as it were if you had correct and normal dopamine production. So when we're looking at it in that way, some of the motor symptoms start to come up around I think 30 to like 60% when there's more neurodegeneration, and this disease is progressive. As of right now, there is currently no cure, but we're looking at it where this disease, the 2% that it really does affect is going to be individuals 65 and older, but onset can be as early as 40 years of age. And so it's very important to really just focus on being aware of looking out for the signs and symptoms. If your family member has it, just being aware of certain signs that you want to look for it as well. It's also going to be a lot more common in men too. Normally, for some cardinal signs, you're going to be looking at some sort of rigidity. Usually, most of the time, their posture will be shoulders are forward and rounded, head is in this forward position, and they're going to be kind of walking in a shuffling or festering type of gait. Right? No arm swing. Looking at a blank face. You're also going to be looking for the term is bradykinesia. That just means that the movement is very slow and it's not as controlled, right? The body wants to move fast, but you are moving slow, and that's also going to be paired with hypokinesia, which is smaller movements. So it's moving slow and very short, super tiny movements, right? You're also going to have some postural instability. So meaning your balance and your walking is going to be impaired as well. We also have tremors. Resting tremors will kind of look as obvious as this, or they could be very subtle where it's just a very subtle flicker of the fingers. And with that, there's also some non-motor related symptoms to look out for as well. We're looking at reduced sensation. We're looking at impaired swallowing and speech. And there is a chance that dementia may be paired with this diagnosis. It's very hard to tell, right? It is a higher chance of being paired with dementia, and you also have some sort of GI dysfunction, urinary dysfunction, and sexual dysfunction as well. So all of those systems are going to be impaired just because we don't have that control anymore, and it's going to start to progress. And we need to be aware of that and be prepared for that and how to manage those things. And in terms of management, we have a plethora of ways to slow down the progression of Parkinson's, and that's the goal that we're trying to do. We're trying to slow down Parkinson's and preserve your quality of life until the very end, just so that we're giving you that time to really manage your symptoms how you want to do it. You can manage them with pharmaceuticals. There's medication like levodopa, right? You also have antihistamines, anti-cholinergic agents, I believe that's how you pronounce it. I'm sorry if I butchered that. You also have antidepressants as well, just because individuals with Parkinson's tend to have depression, and so we pair that with them as well to really get the mental health aspect of a neurodegenerative disease, just because we like to prioritize the patient initially. Also, there's beautiful programs such as the POWER program, and we're also looking at LVST Big. Those programs really promote large amplitude movements, right? And we want to promote those big movements to really break away that pattern of small, tight, and rigid. And those are some great resources to really look into, and I highly encourage you to look into them as well, okay? And if you have any questions, again, my name is Jacob. Thank you.